You can lose it diet and exercise. You can starve yourself. You can go get bariatric surgery. You can take medications. But if you don't use that in conjunction with those lifestyle changes, you're not going to be as successful.
Healthy isn't just what you do, it's who you become. I'm Dr. Vickie, and this is Healthy Looks Great on You, a lifestyle medicine podcast to help you reclaim your energy, your focus, and your well-being. Life tested, doctor approved. Today on the podcast, I have Dr. Suzanna Chatterjee. She is board certified in both obstetrics and gynecology, as well as obesity medicine. So welcome to the podcast.
Thank you. Thanks for having me.
You're welcome. Well, please just tell us a little bit about what you do, especially with regards to obesity.
So it's interesting. Of course, I've started in obstetrics and gynecology. In my residency, though, I started with an interest in obesity and didn't really even know it. We had to do a research project. My research project ended up being outcomes in pregnancy for the super obese, which would be BMI of 40 and above, which back 15, 16 years ago wasn't super common, but it was becoming more common. Now it's very prevalent. So I did research. We ended up collecting, I think, 107 patients in the 3 years that I did this study, and was able to present that at ACOG, our governing conference. And then I was actually selected we have an alliance with the Japanese Society of Obstetricians and Gynecologists. I was able to go to Japan, to Sapporo, where the beer's from, and present my research there. And I actually won first place in an award because the Japanese were so intrigued by this concept of having so many patients with high BMI. So that's kind of where I started being interested in it. The other thing is, personally, I've always had metabolic problems, and it's long line from my mother's side of obesity in the family, and diabetes and all those things. So I had a personal interest because I've always struggled myself with my own weight. So moving into becoming an OB-GYN, of course, we see patients that they get pregnant, or they're trying to get pregnant, and they struggle with those things as far as like how much they gain and what the recommended is for weight gain in pregnancy. And so I found that I've really always kind of treated weight management, and then we do things like treat PCOS, which is going to be insulin resistance, and treating other metabolic problems. And so it really has always been core to what I do. So fast forward to 2018, my husband and I opened a medical spa while I was in an employed OB-GYN practice. And from there, we started doing some medical weight loss. And so that was just supervised weight loss. That was before GLP-1s came out. And so we were doing things like phentermine and some of these other things. And you could either get them name brand or compounded. And we would partner with pharmacies and do that. So we saw patients have success with that. The hard part with that is you can't really do those medications long term. And there's lots of contraindications or side effects to those medications. And also, the weight loss isn't great. So it was successful, but not great. And then we start having things like liraglutide, then came the Ozempic and Wegovy, and then, of course, Mounjaro and Zepbound. So things have evolved. And so in that process, we continue to do medical weight loss and include GLP-1 medications, and saw that patients did exceedingly well and reacted very well. And then, of course, all the studies have come out about all the other health benefits there are aside from just weight loss. So with that, I thought, well, if I'm doing so much of this, I might as well get a little bit more education in it so that I really can truly understand the physiology and the science behind weight and metabolic syndrome. So I studied through Cornell for obesity medicine, and then took the boards in it. It's been very helpful because we don't really learn in medical school some of those things. I touch on it just very surface, but to deep dive into the physiology of how our metabolism works and how insulin resistance works is pretty interesting.
Well, and I think the research has just exploded in this area.
Yeah.
And with the introduction of the GLP-1 medications, it's been a total game changer.
Yeah.
And so I always take my listeners to what I call mini medical school. So if you would take a mini medical school and just explain what is a GLP-1. I used to say the shot, but now there's obviously an oral form. Let's first talk about what it is, and then we can talk about, like you mentioned, all of the different things that it's being used to treat, and then possibly
what are some drawbacks. But let's start with just GLP-1. We throw that around all the
Yes,
time.
so that's glucagon-like peptide 1. What it is an insulin sensitizing molecule. And so what happens is when our body sees carbohydrates, sugars, our pancreas starts putting out insulin. And what insulin does is actually stores that energy as fat or other deposits. And so that way down the road, because our bodies are meant to be, we protect ourselves, and there's all these evolutionary things that have happened. And so in the event that we come into a point where we don't have access to food, then our body is able to break down some of those stores with glucagon. And so basically what happens is our body sees carbohydrates and sugar, our body puts out insulin. The more that you eat carbohydrates and sugar, you put out more insulin. Or if you have a metabolic problem where you have some insulin resistance, where you're resistant to that insulin, then our body has to produce more insulin. And then that's where we see weight gain or inability to lose weight. So what the drug does is actually help you to not have to put out as much insulin, and then to be able to actually use some of those stores and break down some of that. Now, of course, so this kind of gets into the drawbacks, is it doesn't know fat versus muscle. And so you have to really make sure that you're eating appropriately with it. It's a tool just like anything else. And so even if you have bariatric surgery, of course, you have to make sure you're getting proper nutrition. And so it's really critical, because what we don't want to happen is to see muscle wasting that occurs with the medications. So what I tell patients is that if you eat a high protein diet with the medications, you're going to be more successful. And also that helps with side effects as well.
So lifestyle, this is a lifestyle medicine podcast. I got board certified in lifestyle medicine about the same time that you were pursuing that. And the first two pillars of lifestyle medicine are nutritional eating and exercise.
Yes.
And so I think people have got to embrace, like you said, it's a tool, and you have to embrace lifestyle changes as well. But it's not only being used to treat weight loss, it's being used to treat a variety of things. And there's some promise in lots of areas. So let's talk about that, because it's exciting.
Yeah. So for me personally, the big thing is infertility and PCOS. We see so many women that struggled with getting pregnant, get on GLP-1 medication, and then next thing they've lost. We always say if you lose 5 to 10% of your body weight, your ovulatory function typically returns. So we're seeing so many of these patients that for years and years could not get pregnant, now getting pregnant, having healthy pregnancies and healthy babies, because not only are they correcting their metabolic problem, but then they're starting out their pregnancy at a healthier weight. And so then that pregnancy is even healthier. So it's great there. The CREST study was done, and that was looking at semaglutide treatment of patients. And I believe there was about 17,000 patients in that study. And what they found was there was a 1 in 5, so 19% decrease in all-cause mortality. So that means 1 in 5 people didn't die for any reason. And these were not diabetic patients. They specifically excluded diabetic patients. So 1 in 5 people didn't die just because they were taking semaglutide when they would have normally died. And that's 17,000 people. That's a lot of people. So that was a really powerful study. The other thing that's come up is fatty liver. So we see that fatty liver is treatable, which before we didn't really have a treatment for it. And we're seeing that fatty liver is actually reversed. Previously, the only way to really reverse that was to do bariatric surgery and to do like a Roux-en-Y, which is a very involved, invasive bariatric surgery that can lead to other complications. And so that was really the only way to treat it previously. Now we're seeing that a weekly shot can do that same thing. And then the other thing from a standpoint of Mounjaro or Zepbound that has, so it's a GLP-1, it has a secondary component, which is a GIP. So that medication has been approved for sleep apnea as a primary indication. So if you have sleep apnea, you're on CPAP, you can get the medication as a primary diagnosis for that. And then the other big thing is cardiovascular risk. So we see a lot of older patients that have cardiovascular disease of some sort. Medicare is covering GLP-1s for them because they're actually having improvement in their cardiovascular health. And it's interesting because, and I didn't know this at the time, now they've done studies of it, but I had patients that would start on GLP-1, they go back to their primary care and they would get blood work done and their cholesterol had improved. and they hadn't really changed much other than they were eating more protein. So they thought maybe my cholesterol will be worse because maybe I'm getting more fat from red meat and that type of thing. And actually their cholesterol in a lot of situations had improved. So I have lots of patients that have come off of statin drugs for cholesterol. They've come off of their hypertensive blood pressure drugs. So it's really been seriously life altering and life saving as a medication.
Absolutely. Now, what about drawbacks? One thing I've heard about is visual issues. I don't know how significant that is, but again, the bigger concern is probably gaining the weight back once you stop the
Yeah.
medication. Is it
Yeah.
forever
So,
medication?
yeah. So I talk to patients when they go to start, I tell them this is not a like lose weight, get to my goal weight and stop type of thing. Because with anything, even if you have bariatric surgery, you have to maintain that weight. There is something in our brain that has a set point, just like our body has a core body temperature. For women, we have a menstrual cycle that is regulated by our hormones, by our brain. So if you look at the set body weight that we have, our body has a set point. And so, for instance, if you're a certain weight and you have that weight for a long time, let's say you go on vacation, you might gain a little bit, and then over the course of the next few weeks, you lose that weight and you go back to your set point. Let's say the opposite's true and you diet and exercise really heavily and you're very dedicated to it, and you may lose 5 or 10 pounds, but then you stop doing that, then you go back to that set point. So what I tell patients is that if you're going to do this, I need you to commit to at least 3 years, maybe longer, but a year or so to get the weight off, 6 months to a year to get to that goal point, and then we need to maintain it for 2 years. And maintenance looks very different than actual like treatment phase, because we're going to drop the dose down to something low, but just still keep a little bit of that medication in your system to keep you from gaining it back. Because I have patients that don't listen, and I've seen this because I've been doing this a while now, and invariably a year later they come back, they've gained 20 to 30 pounds back, and they want to get back on it. And what I have seen is that the getting off and on, each time you do that, the efficacy and the weight loss is diminished. So you don't respond as well because you're not naive to the drug, your body's seen it before. And so I see it all the time, and then patients get frustrated. So what I tell everybody from the get-go is we're going to do 3 years. Now, that being said, there are people that have true insulin resistance, and it may be subclinical insulin resistance. Like we test them, test their insulin levels, they seem to be normal, but they may have something going on. And so for those patients, maybe it is a lifelong thing. Or for patients that have sleep apnea or have cardiovascular disease, maybe it is a lifelong thing, but not necessarily at high doses. So drawbacks, like I said, the muscle wasting is a big thing. People talk about Ozempic face and those types of things. Fat is a natural filler, and so we do age or appear to age with weight loss. And for some people, they find that that can be troublesome to them because they feel like they look so much older, they look sickly. And that's where it's important to really have normal or have a realistic expectation of what your weight is. Because I think sometimes what happens is you've been overweight for so long and then all of a sudden you're really successful. Sometimes we take it a little bit too far, and I think there's some body dysmorphia that does occur. And so it's really important to keep an eye on things, keep an eye on BMI, make sure that we're not getting underweight in the process, because sometimes that does happen and that's not healthy either.
That's so fascinating. It's really just so interesting, and talking about a set point. And I do believe you can change your set point. And I think
Absolutely. Yeah, if you maintain it. And that's what I tell patients, for instance, when they get pregnant. So that's the easiest thing for me to relate it to. It's 9 or 10 months and you gain some weight, but then typically if you put the effort into it, you can lose the weight postpartum. And so our body wants to be at a certain set point. And so if you temporarily gain or lose weight, then our body's going to go back to that set point that we have.
So on the muscle wasting, I do understand the importance of protein, but what's the role of exercise in that? Do people lose muscle so they're weak and they're unable to exercise like they could previously, or does exercise mitigate some of that?
Oh, absolutely. Exercise mitigates it. I think the hard part is that we've always looked for the quick fix. And so for patients, it's, I want to lose weight. And so this shot will make me lose weight. And I think a lot of times, instead of using it as a tool in your arsenal, it's the primary thing. So I see patients that come in and say, I'm not losing weight like I used to, or I'm not being successful. And you start talking to them about diet and they're not eating properly, or they're not eating at all, and then they're not exercising. So those are questions that I ask, is what kind of physical activity you do. And it's interesting because if you've written prescriptions for these GLP-1s and you do a prior authorization, one of the questions that you always have to answer is this medication being used in conjunction with lifestyle changes like altering diet and exercise? And you have to answer yes to that. If you put no, then they don't approve the drug. So this is something that is really critical. So even in the authorization process of the medication, they've put this little thing in there to kind of tip you off and go, okay, this is not just for taking a shot every week and then just live your life however you want to. I mean, you really have to put the effort in. It's just like bariatric surgery. If you go get bariatric surgery, you may initially lose some weight without doing anything differently. But over time, if you don't exercise and eat properly and eat a balanced diet, you're going to gain weight back, or you're going to plateau. And we see a lot of bariatric patients suffer from that as well. So again, I tell people you can lose it diet and exercise, you can starve yourself, you can go get bariatric surgery, you can take medications. But if you don't use that in conjunction with those lifestyle changes, you're not going to be as successful.
Which are hard. Lifestyle changes are very, very hard. And, with lifestyle medicine, it's whole food, plant forward diet. And for me personally, I'm not vegetarian. I probably say I'm 80-20 when I would eat meat, maybe 20% of the time. And so I had a conversation with my friends around the dinner table the other day, and they were like, well, we're trying to eat more meat because we need to get more protein, which I personally think is a huge marketing thing to some degree. You walk through the grocery store and every package will say protein, so many grams. You can buy total junk food just because it has protein on the front that's doing nothing. But I asked them, why are you doing that? Why do you think you need so much protein? Because I think people overestimate their needs sometimes. And they said, well, they wanted big muscles. And I have these gigantic biceps. And I'm like, well, I mean, you got to go to the gym to get biceps. Eating protein is not going to give you biceps. But my question is, do you need more protein if you're on one of these medications?
I don't think that you need more protein as a baseline, but I think everybody, whether you're on a GLP-1 or not, needs to eat a balanced diet and have protein there. Because even if you just look at aging, I mean, we lose muscle mass, and protein is a component of our muscle. So no, you don't need to eat tons and tons of protein to build muscle. You've got to eat some protein, but then also exercise those muscles to grow them. It does take protein to do that, but you don't have to just eat a ton of protein and just do a carnivore diet in order to be successful.
I think most men who eat the standard American diet probably get more protein than they need.
Yeah.
And most women who are not plant-based are getting enough protein. But then on top of that, people are adding all these powders and trying to increase their protein with Greek yogurt and things that are dairy. And I'm just more about quality protein than quantity of protein. And you do have to eat more if you're plant-based. I typically add things like edamame and green peas to anything I'm cooking, lots of beans, lots of nuts and things that are high in protein. It's much harder to get your protein if you're eating plant-based.
Absolutely.
For people that are eating meat, I think sometimes they actually overestimate how much they need. But if it's equal, then it doesn't matter. You just, like you said, you need to eat a balanced diet. Now, ask 15 people what a balanced diet is, and you might get 20 answers. So that's the hard part for people. But I think everyone can agree that whole food is the way to go.
Absolutely. I tell patients that I want you to get such and such target of protein per day. And that's really what I have them look into. And then, of course, have them make sure they're not having sugar, carbohydrates on their own if they're on a GLP-1. But what I tell them is, if you are in an absolute pinch, if it's a choice between a protein powder, a protein drink, a protein bar, the Greek yogurt that has a little bit of extra protein, if it's a choice between that or nothing, I want you to do that. So I want you to go ahead and use the synthetic processed, either dairy or non-dairy, whatever. But my preference is not that. My preference is that you eat whole foods that are eat some chicken, eat some fish, eat some nuts, eat some vegetables that are a little bit higher in protein. That will be the better thing to do. But if it's a choice between nothing or the processed stuff, then that's when I tell people. So it's meant to be, and a lot of these say it on there, it's a meal replacement. So it's a replacement for something. It's not the primary thing. So that shouldn't be your go-to.
And is it because their intake is so much lower when they're on the GLP-1s?
Yeah, I think you have to make yourself eat. You're not hungry. And then I think, and this is what I talk to patients about, is as children, we are taught to, if we feel nauseated, to eat a brat diet. So starches, bananas, rice, applesauce, toast. That's what you're supposed to eat, or saltine crackers or something like that. So with a GLP-1, it's very different because, again, we're sensitizing our insulin. So if we put a starch in or something that has a high glycemic index instead of something that's more protein rich, then we feel worse. And so then it's like, then you just don't want to eat. And then we're in a situation where we're shutting down our metabolism and you just feel sick all the time. And those are patients that then fail the medication, because I tell people, if someone says, I can't take a GLP-1, it makes me too sick, that is user error. It's not the medication. Because there's no way that if you are eating appropriately that you should fail the medicine, unless you have a contraindication to the medicine or you've had something like pancreatitis. But other than that, I tell patients all the time, if you have failed, patients that say they can't take it, and I ask them, well, what did you eat? Well, the answer is, I didn't eat. I just didn't have an appetite. So that's a problem. Or they'll say, well, I would get nauseous, so then I would eat some pretzels, or I would get nauseous, and so I eat a piece of toast. And so we're trained as children to do that. Even when you're pregnant, let's eat starchy, salty foods until you get through that morning sickness. But this is different. And I try to explain to patients why, because it's a completely different mechanism. And so once they understand that, my patients do so much better, because I tell them, if you get nauseated, I need you to eat 20 to 30 grams of protein. Just right off the bat, 20, 30 grams of protein. However, if you can do nuts. And then again, if all you can get a hold of because you're running, and I'm guilty of this because of my schedule, I'll grab a protein shake in the morning, because it's either that or nothing. And so again, it's not ideal, but it's better than nothing.
Do you have a formal process for counseling your patients about lifestyle changes, or do you send them to someone else for that? Or
I do that all. So I do that within the consultation, and I talk to them. We go through all these things and we talk about it. And then I follow up with them regularly, and they have me for support. I have nurse practitioners that work with me as well, and nurses that kind of help out with that type of thing. But I tell them all the time, call me if there's any questions. I'd rather you call me and ask than just try to assume or try to figure out on your own, or sit there and think, this isn't working for me. There's something we can do to probably make it work better.
Well, that is really fascinating, and I think it's exciting. I know there's ongoing research in other areas. I think some of the studies that I've seen on dementia prevention have not really panned out as well as we had hoped, but there is also some potential with addiction.
Yeah.
And so it's just exciting to see that understanding. You mentioned in medical school you didn't get a lot of training in that. Well, I don't think that anybody really knew a lot of this, certainly when I was in medical school. And so it's just an area of research that's exploded. Our knowledge in this area has exploded, and now the tools in the toolbox have really increased, and it's a wonderful thing for people, I think.
Yeah, and there's a lot of exciting things coming out. You mentioned the pill, and that's huge. A shot every week it's a lot to ask people to take a shot, to have oral medication that is as effective. And that's what it's really showing. It's showing that there's equivalency there. And so with Wegovy, they were only able to name it Wegovy if they could prove that the efficacy was the same as the injectable. And they were able to do that, which is pretty remarkable in how they formulated it. Because so Rybelsus is semaglutide oral. We've had that for many, many years for diabetic patients, but it had a lot of side effects and it didn't really cause the weight loss, and they didn't know why. So they started reformulating and figuring out how they could orally do this. And it's really fascinating. One of the reps was explaining to me, it's encapsulated, and the encapsulation is kind of sticky, so to speak. So when you take it, you're supposed to take it on an empty stomach. It actually sticks to the mucosa or the lining of the stomach, and actually diffuses that medication into your bloodstream almost like an injection would. And then you're supposed to eat about 30 minutes later. That knocks off the capsule and stops that process and that absorption. And that's how it works, which is incredible. So you can wait longer to eat, but then you're going to start feeling nauseated because you're getting that absorption. But they really have formulated something that's pretty neat. And then, of course, there's other drugs that are coming down the pike that we hear a little bit about that we don't know when they'll be released, but both Eli Lilly as well as Novo Nordisk each have drugs that they're looking to release, hopefully sometime later this year or next.
Wow, that's mind-blowing.
Yeah.
That's really exciting.
Yeah.
Well, thank you so much for sharing all of this. And I think this is something that my listeners will really be interested in. And I appreciate your time.
No problem. Thank you for having me.
If you enjoyed this episode of Healthy Looks Great on You and you want to learn more about how lifestyle medicine can actually move the needle on your health, then head over to healthylooksgreatonyou.com. You can subscribe there and get every episode delivered straight to your inbox so you can listen with just one click instead of trying to hunt it down. I've also got some great free resources waiting on you, including my pantry guide. It's a simple list of 10 staples that you can keep in the pantry and 10 staples that you can keep in the freezer to make healthy eating easier, even on busy days. And of course, make sure you're subscribed on Apple, Spotify, YouTube, or wherever you're listening so you don't miss an episode. You can also learn about the Healthy Looks Great on You Lab. It's my private community for women who want simple, sustainable habits without overwhelm or relying on willpower. I'd love to see you join. The information contained in this podcast is for educational purposes only and is not considered to be a substitute for medical advice. You should continue to follow up with your physician or healthcare provider and take medication as prescribed. Though the information in this podcast is evidence-based, new research may develop and recommendations may change.